thank you so much for joining today. But I think it is probably a bit of a reflection of the interest in the area and the very exciting advances we have seen over the last few years. I guess some people considered hypertension a bit of a boring area, but in the last few years, it really has become a very exciting field. So we're up for a treat today, and we have a stellar lineup of experts talking about uncontrolled hypertension and how we can best deal with it. I would also like to take the opportunity to thank Hypertension Canada, Anna in particular, for all the hard work of bringing this together. And I hope you find this activity today educational. So without further ado, I would like to introduce the first speaker, which is Professor Jan Danser. And obviously, he doesn't really need any introduction. He's a real expert, particularly in the context of the renin-angiotensin-aldosterone system. He has done groundbreaking research. He's currently a professor of pharmacology and heads the division of pharmacology within the Department of Internal Medicine at the Erasmus Medical Center. And his research focuses on the pathogenesis and therapy of hypertension with special emphasis on the renin-angiotensin-aldosterone system. And today, Jan will educate us about the new exciting injectable silencing RNA therapies for hypertension. Jan, over to you.
So thank you very much for your kind introduction and for inviting me here. And indeed, I'll be talking about the silencing RNA therapies, which is indeed a new topic. These are my disclosures, which we already discussed. Let's start with the renin-angiotensin system, which I'm sure is familiar to most of you. And of course, we have multiple drugs interfering with this system. And so we have the two enzymes here, renin and ACE, and we have the receptor. And as you know, we have ACE inhibitors and angiotensin receptor blockers and even renin inhibitors, which are interfering within the system and are used widely as antihypertensive drugs. You might wonder, why do we actually need new drugs which also interfere with this system? One of the issues I think is illustrated on this slide. What we actually see here is, and this is well known in many hormonal systems, is that when you block at any level in the system will try to come back to its original state. And for instance, if we have too much angiotensin 2, it will suppress the activity of renin and the concentration of renin, and then the system will normalize again the angiotensin 2 levels. But also when we block angiotensin 2, then we have the problem that there's not this stimulation of the AT1 receptor is no longer happening. And then, of course, the opposite will happen. We get a lot of renin, and actually it might bring back the system to the original level, even when there's ACE inhibition or angiotensin receptor blockade. And so how can we prevent this effect, and which actually might mean that the drugs do not work as well as we'd like them to work? And well, one other possibility would be to interfere at the level of angiotensinogen. This is the substrate from which all the angiotensins come from. And actually, we have enormous levels of angiotensinogen. They're about 10 million-fold higher than those of angiotensin. That also allows a rise in renin to immediately generate more angiotensin and to cover, well, whatever degree of inhibition is happening, as I just mentioned. But of course, if we take out angiotensinogen, the story might be different. And then maybe no longer we have this feedback loop working as it normally does. And so for many years, this was not possible. It's not an enzyme, it's not a receptor. And of course, most drugs we have acts on enzymes and receptors. This is a substrate. But now we have a new tool, and it's either a so-called antisense oligonucleotide, ASO, or siRNA. And the difference is that this is a single strand, and here we have double strand for the siRNA. And both of them are capable of binding to the messenger RNA for angiotensinogen, and then making sure that it will be destroyed. And the single strand has a relatively short half-life of maximum some weeks, whereas for the siRNA, the double strand, it actually is a very long half-life, and it might even be months. And here we see a paper which I like to show you, just because it's such a nice paper which illustrates a lot of background on this topic of interfering at the level of RNA. So I'm just showing you the paper, and I quote one a graph from this paper, one figure, where you actually see how all of this might happen. And this is actually the example of the so-called PCSK9, because already there we also have siRNA tools. This is the enzyme proprotein convertase subtilisin caxin type 9, and I'm sure you know this. It's normally involved in the degradation of the LDL receptor. So then we have less LDL receptors and LDL levels will go up. But of course, if we would take out this PCSK9, the opposite might occur and we might lower LDL. And this is now possible with siRNA. And actually, this PCSK9 is liver-derived, and that resembles, of course, what is also true for angiotensinogen, which is also liver-derived. And so the silencing interferon RNA will go into the liver, in the hepatocytes, and make sure eventually that this PCSK9 messenger RNA is destroyed, and so it can no longer be made. And we already know that one injection of this PCSK9 siRNA actually works for 6 months. So it's really a very, very long half-life of this type of drug. And now we go back to angiotensinogen. Well, this is also liver-derived, like PCSK9. So actually we can use the same tool here. And because one aspect, of course, we have these drugs, how to get them to the liver. And this was already solved, in fact, for the PCSK9. And the same trick can be used here. It makes use of a receptor, which is called the asialoglycoprotein receptor, which is abundantly expressed on hepatocytes, more than 500,000 receptors per cell. And it has high specificity for this so-called N-acetylgalactosamine group. So if we add that to the siRNA, it will allow the siRNA to bind to the receptor and to really only go to the liver, accumulate in the liver. And well, these receptors will internalize the siRNA. And then after one injection, this drug will immediately be targeted to the liver, accumulate there. And as we've seen for the PCSK9, it can even allow effect for 6 months, only one injection. Well, what about the angiotensinogen? Can we repeat that kind of thing for angiotensinogen as well? And we started off a few years ago where we did studies in rats, spontaneously hypertensive rats, and we now used indeed this siRNA. And we also made a comparison with the classical angiotensin receptor blocker, valsartan, or we used the combination. And as you can see on the left part of this slide, we look at the angiotensinogen levels. And already with valsartan, there's a tendency for angiotensinogen levels to go down a little bit. It's mainly due to the fact that renin is very, very high during such blockade of the receptor. It's the feedback which I just mentioned. But please note the difference in scale here. And now with angiotensinogen siRNA, really the levels go down enormously, and by 98% almost, and it's even slightly more, 99.8%, so it's almost gone actually when we have the combination with valsartan. And it's again due to the fact that now there's not only diminished synthesis because we take out the messenger RNA, but also these very high renin levels. And then, of course, angiotensinogen is being reacted with, and then it's also gone. So that's why we have this huge effect and even further going down when we have dual blockade. Well, what about blood pressure? You can see it here. And then we see the black line on the top is vehicle. Then we got valsartan and angiotensinogen siRNA, the 2 lines below that. And you see they're actually identical. And so we can see already here that angiotensinogen siRNA alone is as good or has the same effect as valsartan. But when we combine the two, and remember that at that moment, almost the angiotensinogen was gone, 0.1% was left, then we have a huge synergistic effect. And now there's almost 75 milliliters of mercury difference in blood pressure. So a really huge drop in blood pressure, synergistic effect, reflecting what I just showed you, that really the angiotensin activity is almost gone to zero. Well, what about the humans? And there's already some data in humans published last year in the New England Journal of Medicine. And here you see a paper about these first data. The drug now has a name. The siRNA is called zilebesiran. And of course, at that time, the first studies, the phase 1 studies, they didn't really know what kind of dose to use. So a whole range of doses was tested, going from 10 to 800 milligrams. And you can see here a scale for 24 weeks, which is indeed 6 months, identical the long time which, for instance, this PCSK9 siRNA is acting. And you can see here that when the drug is given, well, first of all, it's not surprising, and that in a dose-dependent manner, the angiotensinogen is going down already within 1 or 2 weeks. But then actually importantly, that this effect really remains present for, as you can see, up to 24 weeks. And again, this is just one injection of this drug, zilebesiran. Well, then we look at the blood pressure here, various doses of zilebesiran, 200 milligram, 400 milligram, 800 milligram versus placebo, week 6, week 8, week 12, and week 24. And the important message is, first of all, of course, a dose-dependent lowering of blood pressure, systolic and diastolic, as you can see in the two colors here. But actually, this effect remains present even until week 24. So again, here, like the lowering of angiotensinogen, also the effect on blood pressure lasts for about, well, 6 months minimum. Well, there's some new work, of course, ongoing now that we have these first data. And these trials are called, in phase 2 trials, Cardia 1 and Cardia 2. In the Cardia 1, actually, there's some additional work being done with this drug zilebesiran in, as you can see here, patients with mild to moderate hypertension. This is a large study which will incorporate a lot more patients than the one which was used for the New England study. It's supposed to be completed by the end of this year. And a second study, Cardia 2, where the drug is being tested on top of other antihypertensives like olmesartan, another angiotensin receptor blocker, calcium antagonist, or a diuretic. So I'll show you some data which have been published or are being released during meetings. It's not that much at the moment. This is the first paper. It's a paper published in JAMA just a few months ago. And what you can see here is again zilebesiran given at 150 milligram, 300 milligram, and either once or every per 6 months or every 3 months, or 600 milligram. And again, it's compared to placebo. And you can see that after 3 months, this is the 3 months data, that of course, again, we can see here, and on the right, maybe it's a little bit better, you can see it because that shows the delta at that 150 milligram, 300 and 600 all cause a big drop in blood pressure as compared to placebo. And at the bottom, you see the 6 month data. And now we have 300 milligram twice because it was only given in a certain patient group once per 6 months, or it was given every 3 months. And here you do seem to be seeing a little bit dose dependency, 150 milligram, 300 once, 300 twice in the 6 month period, and 600 milligram once. And you can see that, well, the effect of the 150 milligram dose is the smallest. And then from 300 milligram up to the 600, you get a little bit bigger effect. So this is very promising data. Well, what about the combination? Side effects I should mention. Again, this is still, although the numbers are about 80 or per group, it's still quite modest, of course, to really address the issue of side effects. But at this moment, actually, there's no serious side effects which have been reported with this drug. And then the other, the Cardia 2 trial, nothing has been published, but this data was released at a recent meeting. I think it was the ACC meeting earlier this year in the United States. And here the zilebesiran was given on top of the diuretic, the calcium antagonist or an AT1 receptor antagonist. And you can see that, again, both for diastolic and systolic, that there is an additional effect, and which is actually the biggest for the when the drug was given on top of indapamide, so the diuretic. But even with amlodipine, also olmesartan, we see additional effects. So it has effects on top of other treatments. The final issue I'd like to discuss is that, of course, this is a completely new type of drug, which really acts, well, possibly for even 6 months or maybe even longer. And it might be that there are, of course, emergency conditions when suddenly we do need the renin-angiotensin system again. Of course, this could happen. It's not a system which we can miss completely. There are cases where we might need the system in shock, but also, for instance, in pregnancy, there are conditions where you really like to have the system normal functioning. So what can we do in such conditions? And we addressed a few issues here, again, in animal work. So for instance, you could speculate that conventional vasopressors, like actually angiotensin II itself or norepinephrine, can be used to increase blood pressure. And here we again made use of these spontaneously hypertensive rats. You can see it here. We put them on a low salt diet to make them truly responsive to a blocker of the renin-angiotensin system, the siRNA in this case. And then we took blood samples. And also we verified the effect of acute pressure doses of angiotensin II or noradrenaline. And we also performed a somewhat longer-term treatment with either a corticosteroid, fludrocortisone, we used an alpha agonist, or we gave them a high-salt diet. And we quickly go to the results. Here you see the effect of adding acute bolus injections of angiotensin II on top or noradrenaline at the bottom at baseline and also after the siRNA. So you see this still functions. So that's one way of increasing blood pressure acutely. Well, what about these chronic treatments? Here we see the blood pressure lowering after the siRNA. And then, yes, all treatments, at least 2 of the treatments were effective. So fludrocortisone in blue brings back blood pressure to its baseline levels, and so did the high salt level, actually the fastest of the 3. And somewhat surprisingly, we were unable to see an effect of imidodine, the alpha agonist, even when we increased the dose at the very last part of the study. For this, we still do not have an explanation, but at least the high salt diet and the fludrocortisone are very effective at bringing back blood pressure. And the final issue, very recently published, this is an elegant new approach, because this is actually a novel type of drug. It's called Reversir, and the name already says it. It reverses the effect of the siRNA, hence the name, of course. So it acts exactly the same. It's also targeted to the liver, and actually this is an siRNA which will bind to the angiotensinogen siRNA itself and destroy it. So make sure that it doesn't act 6 months anymore, but it can be destroyed within actually days. So here you see some examples of this work, which is recently published in Hypertension. And actually, see here, it says 2014, which should be 2024. Sorry for that mistake. We look here at mean arterial blood pressure. Well, of course, if we give the siRNA again, we can see on the left the absolute values, on the right the delta. Maybe the right is the easiest to see. And then, of course, we see siRNA, we see a nice lowering of blood pressure. Then we tested 3 doses of this Reversir, 1, 10, and 20. And I should mention that the siRNA was given at 10 milligram per kilogram. So we used that same dose for the siRNA. We went a little bit higher, 20, and also 10-fold lower. But interestingly, as you can see on the bottom, the red line represents no Reversir, so then blood pressure remains low. But all 3 other colors, we see an increase in blood pressure to actually the baseline levels. So all doses of Reversir were actually capable of reversing blood pressure again and returning it to normal. Although this took a few days, so not an acute effect. This is about 1 week to scale at the latter part of the study, of the graph. And then what about angiotensinogen? Here you can see that with the 10 and 20, that's at the left bottom, with the 10 and 20 doses, we can see that actually the angiotensinogen levels, first they went down, but then when giving the siRNA, you can see that they go back to where the black level, the black line is placebo. You can see that they return fully to normal. Only the 1 milligram dose, the brown color, you can see that actually it did return to some degree, but only about 50%. And then a little bit more complicated graph on the right. Here we see, first of all, that when we give the angiotensinogen siRNA, as always, renin levels will really go up. And this is a log scale, so there's massive rises in renin. Nothing surprising there. If we don't give Reversir, it remains high. That's the red line. Then the orange and purple line, you see that renin actually fully returns to its normal levels, which were also shown in, seen in placebo-treated animals. Only the brown line stays a little bit, about 2-fold above that, or the original line, the concentration in vehicle-treated animals. Although it's not significant, but still it's about 2-fold higher. And remember, on the left, you see that also the plasma angiotensinogen was only about 50% back to its original levels. So by having higher renin levels, 2-3-fold higher, and still somewhat lower angiotensinogen levels, apparently, what you saw on the slide before, blood pressure was still capable of returning fully to normal. So this is, again, an example of how the system is functioning. Playing around with renin levels, we can still allow blood pressure to return to its original status, even when angiotensinogen is not fully normalized. So my final slide. Might this be the future backbone of treatment? We have a drug here which really exerts very long-lasting blood pressure lowering effect. 1 injection might even act for 6 months. We've seen additive and possibly even synergistic effects occurring with other antihypertensive drugs. And a major problem, of course, in hypertension is not that we don't have drugs which are really not working. We have many drugs which are excellent drugs, but a major, if not the biggest problem is that people don't take their drugs, non-adherence. And this injectable drug, which acts for 6 months, might, of course, be a solution for this major problem. There are some safety issues. This is a very long-acting drug. Can we somehow get rid of it? It's not something you can take out of the liver, of course, once it's there. But we have a new tool, for instance, Reversir, which can annihilate the angiogenogen siRNA in just a few days. And other tools, acute vasopressor drugs like noradrenaline and also angiotensin might help to bring back blood pressure if needed. Thank you very much. I'll stop sharing.
Jan, wonderful presentation. Thank you so much. And again, I think one of the most exciting developments, obviously, in the context of weight loss, in the context of management of lipids. We have already initiated the era, but it's pretty new in the hypertension world and can really make a huge difference. One question I had, if I may, you already showed, which I think is an important slide, how these novel tools work together with other antihypertensive drugs we have available already. And perhaps not surprising, at least to me, was that diuretics and calcium channel blockers obviously work very well together with a compound that targets the angiotensinogen-renin and angiotensin system. And that the ARB perhaps is not the perfect partner because we've targeted it already. But is that, I mean, that's just my simple mechanistic kind of thinking, but is that backed by some data? Would you think that, you know, if we can establish that these approaches are safe and effective and could be the backbone, as you indicated in your last slide, would then perhaps be diuretics and calcium channel blockers the most logical partners to achieve blood pressure control?
Well, I think this is a very important issue, and you're fully right, of course, that if we have already one blocker on board, you might wonder, do we need a second one? And we also know, of course, that blocking the system, let's say too much, with maybe even 2 or 3 blockers of the renin-angiotensin system might also not be something which is really what we'd like to achieve in every patient. It might be that some patients do require 2 drugs, but of course, mostly you would like to rely on several types of drugs acting at several or different mechanisms, and then of course an ARB or a renin-angiotensin system blocker like the siRNA together with a calcium antagonist would be a logical choice, and perhaps even together with a diuretic or maybe all 3. All this is possible. And yeah, the difference would be, of course, that now you have at least one of these 3 drugs which the people would get because they get it by injection. And because the issue remains, of course, do people take these drugs? We know they work, but most people forget or don't take it at all for some reason. And then, of course, this option of injecting would mean that at least one of the 3 is acting. So I think that would be an attractive aspect here.
Absolutely, fully agree. We do have a number of questions actually from the audience. One is, Jan, if on high salt diet or normal Canadian salt diet, I'm not entirely sure, you know, how high that is in Australia. It's around 180 millimole. How effective are these silencing RNA drugs? You showed that with saline, you can essentially recover the blood pressure lowering efficacy and counteract it. So if people are on a, let's say, a higher salt diet, would you expect that these drugs don't work as effectively as they could otherwise?
Yes, it's a very important question. And so we have shown ourselves, and I think there's also some data in the New England paper, that in a low salt diet, the responsiveness to a drug like this, the siRNA, would be bigger. And in fact, that's not new at all. I mean, that is valid for every blocker of the renin-angiotensin system. So of course, it's true here. And so, yes, the effect of such a drug like that of an ACE inhibitor or an ARB or a renin inhibitor would be less under high salt conditions. And logically, the reason behind that is, of course, that during high salt conditions, there's suppression of the renin-angiotensin system, in particular of renin release. So it's not very surprising that if the system is not very active, like under high salt conditions, that also the effect of a drug interfering with the system might be a little bit less. But that's nothing new. And I mean, from that perspective, this drug is exactly the same as any renin-angiotensin system blocker. It's not a magical drug which certainly would work also under high salt conditions or something like that. Whatever applies to ACE inhibitors and ARBs and renin inhibitors applies to this type of drug as well.
And, I mean, it was really important to show how you can recover, if there's hypotensive issues. And indeed, this is the next question we have here from the audience. Any data of reversibility of hypotension in acute emergencies? So this is obviously relating to patients.
Yes.
Does it take minutes, hours instead of days or so? Any data from humans? I don't think so, but you probably
no, at the moment is nothing yet. I mean, what probably will happen now is to start using this drug and to do the first test, whether it's safe and what does it do in, let's say, without any siRNA, and then maybe slowly after giving the siRNA, and then of course the final step will be such patients. But that's, as far as I know, is not yet happening. So we need more time.
Yeah. And again, I'm not aware of any data in this context. There's another question: is the drug available? Obviously, not yet. It's still
not
in
no.
Only as part of trials. So these trials are running, as you indicated, Kalia 1, 2, 3. It's an international trial. We're involved in that, and it's quite fascinating. But another important question: any contraindication regarding liver disease? And we had similar discussions like with inclisiran and others. Obviously, you're targeting those compounds in the liver. And any issues with pre-existing liver disease?
No, this is a logical question, which indeed comes up quite often because, this drug is accumulating in the liver. Might that be bad? And what exactly would happen? Well, of course, with the, I mentioned already, with this drug, the experience we currently have is extremely limited and not in thousands of patients or something. So I think based on that, it's really hard to say. Nothing happened so far. But at least for the inclisiran, which you already mentioned, so for the PCSK9, you could say, what about that drug? Because actually it's the same principle. It's more or less exactly the same, except of course it's targeting PCSK9, not angiotensinogen. But the principle, the liver accumulate, all exactly the same. And at least for that drug at the moment, no liver side effects have been noted actually. And if you start thinking about it, what happens is that it is targeting indeed to the liver, but it's rapidly accumulating in hepatocytes, and it's really very, very specific, only acting on the messenger RNA of angiotensinogen. So it cannot do anything else. That's it. And so from that perspective, it also sounds relatively safe, very safe actually, and no reason for any liver-related side effects. Whatever could happen should be related to the fact that there's no longer angiotensinogen. That's what happens. And for the rest, there's no issues that there's like, say, liver toxicity or inflammatory responses or something like that. There's no evidence for that at the moment.
That's very reassuring. But again, we have to wait and get more data. One last question before we can let you go. There's more questions in the chat. Thank you so much for putting these. I just pick one. Does silencing RNA therapies, do they eliminate the diurnal variation of blood pressure? Have you had any experience in that regard?
I don't think there's any knowledge about that at the moment. But to be honest, I wouldn't expect that this would happen. I mean, again, it's like a blocker of the renin-angiotensin system. And I've never heard actually that such a blocker would take this whole rhythm out. So I think it will stay as it is, only at a lower level, of course. But there's no reason to expect that whole will wholly disappear. Yeah.
Fantastic. Now I know you have somewhere else to go, Jan. I release you hereby. Thank you so much for this wonderful presentation, and again, very exciting development. You have a wonderful day. Thanks so much, Jan.
Thank you very much.
We'll continue with the program. Have a great day.
Okay. Goodbye.
All right, now it's my pleasure to talk a bit about another very exciting topic, at least in my view, and these are interventional approaches. So my name is Markus Schlaich. I'm a professor of medicine and nephrologist and a hypertension specialist. And I am here at the Department of Cardiology and Nephrology at the Royal Perth Hospital. Can I confirm that you can see my slides?
Yep.
Yep. Fantastic. Terrific. Thank you so much. So I will give my presentation, after which I will introduce Professor Ernesto Schiffrin, and then we'll have hopefully some time at the end for some questions. So Jan already indicated one important aspect, and that is that non-adherence with prescribed medication is certainly a bit of a big elephant in the room. And this is perhaps one of the reasons why alternative approaches may be required. There's a lot of other ones, but that's an obvious and a very important one. And we always thought I have a specific interest in the role of the sympathetic nervous system. And while I'm talking about this, I'll just show you my disclosures, which you've seen before already. This is an extract from the latest European Society of Hypertension guidelines. And this is actually the first figure in those guidelines. And I kind of like it. You know, it's a very big document, but it has a number of really nice graphs in it. And this kind of illustrates the various mechanisms that are in place. They talk about genetic factors, which we can't cover. They talk about lifestyle factors, which we know are critical, and we always try to convince our patients to adhere to a healthier lifestyle. We're aware of the environmental factors, but as physicians, I guess, and with pharmacotherapy, what we have available, we target those that increase blood pressure here in red, and we've talked about the renin-angiotensin system already. We will talk about endothelin at Ernesto's talk. And then we have some mechanisms that help to mitigate the blood pressure rise or cause blood pressure lowering. And we obviously try to interfere with those that raise it and support the mechanisms that can lower blood pressure. But what is also important here in the center of this circle is the brain. And, you know, the brain, of course, is the home of the central nuclei that determines sympathetic outflow, particularly sympathetic outflow towards the kidneys, but also to all the other organs, such as the heart, such as the peripheral vasculature. And that alone may indicate how relevant this system is. And it is involved in essentially most or all forms of hypertension to some extent. And specifically so in resistant hypertension. I will show you some data, but I just wanted to answer the question whether or not it does make a difference what kind of phenotype we're talking about. And it certainly does. If you look at the outcomes, depending on whether you have controlled, uncontrolled, masked, or resistant hypertension, you see very clearly that those with resistant hypertension have the highest mortality in this context. So there are consequences depending on the phenotype. The other very important general aspect we're all familiar with, and this is why we see these patients and try to treat them to the best of our ability, is that anything you can achieve in terms of blood pressure lowering is usually of benefit for those patients. And if you express that in numbers, for a 10 millimeter mercury systolic office blood pressure reduction, you get around 20% overall relative risk reduction for major cardiovascular events, even more pronounced for strokes and heart failure, not quite so much for ischemic heart disease and overall cardiovascular death, but it's an almost linear relationship. With 5 millimeters of mercury, you get roughly half of that. So this is why we treat hypertension as good as we can. And again, this slide, just to finish the general kind of considerations, is the latest algorithm and iteration from the European Society of Hypertension in 2023, how we should probably treat hypertension in most cases, depending a bit on renal function, pre-existing level of renal function. But the principles are that we target the three major systems, the renin-angiotensin system with either ACE or ARBs, adding a calcium channel blocker and a diuretic. In the context of renal impairment, we may need a loop diuretic. And then if we focus here on the left side, it is pretty well established that spironolactone is an excellent, fourth line, sometimes perhaps even earlier. But we have other drug classes that can be used, if others are not tolerated. And these are the beta blockers, the alpha blockers. We do have actually centrally acting agents, which I use quite frequently. But what is new, and this is the first time that this has made it into the guidelines, not only the European, but very recently also into the European Society of Cardiology guidelines, just released a few months ago, is renal denervation in patients with an eGFR above 40 mils per minute per 1.73 square meters. And this is based on the data that is available. Personally, I think that renal denervation is probably going to make a big difference in patients also with more impaired kidney function, but that needs to be determined by relevant studies. So renal denervation is now considered by guidelines and recommended by guidelines in those patient cohorts. We talked about non-adherence previously, and this is data from a number of studies which specifically looked at patients with resistant hypertension, on average on 4 to 5 prescribed antihypertensive drugs. And you see that around 17% on average did not take a single of their 4 or 5 prescribed drugs, and 44% had what we refer to as partial non-adherence. So they took some, but not all. But it just showcases this is a big problem, and we have to deal with it somehow, and perhaps interventional approaches, or at least having that in our toolbox, may be helpful. So what does renal denervation do? I already spoke about the relevance of the sympathetic nervous system, determined the activity by specific nuclei in the brain stem, in particular the RVLM, the rostral ventral lateral medulla. And the sympathetic nervous system is very flexible. It can actually activate individual organs depending on the situation. And if we have increased sympathetic outflow for whatever reason that is directed towards the kidneys, there's 3 major mechanisms through which this can raise blood pressure. This is sodium and therefore fluid retention. This is vasoconstriction, and of course renin release from the specific juxtaglomerular cells within the kidneys to engage the renin-angiotensin-aldosterone system. So this crosstalk between those systems, it affects the arterioles in terms of vasoconstriction. It increases heart rate once the sympathetic outflow is directed towards the heart. So you get the idea that this is a super controller essentially of cardiovascular regulation, and very frequently involved in the context of hypertension. And I live in Australia, and one of the reasons I moved to Australia in the first place was to work with Professor Murray Esler, who kind of developed the so-called spillover methodology, which is, you know, the only way in humans to assess the sympathetic activity of internal organs. And we looked at renal sympathetic activity, or renal norepinephrine spillover, in normotensive subjects, in patients with essential hypertension and patients with resistant hypertension. And while there is quite some variability, you see very clearly that resistant hypertension is characteristic and characterized by high renal sympathetic drive. So targeting that system perhaps may make very good sense. And renal denervation has a long history. The very first case in the world was done in Melbourne at St. Vincent's Hospital in 2007. At the time, with a single electrode radiofrequency catheter. And it has been a bit of a roller coaster, as most of you would know, but we have now 2nd and 3rd generation devices, multi-electrode devices using radiofrequency energy, or ultrasound-based devices using a balloon device with the ultrasound probe in the center of the balloon, or even injection of alcohol in the periadventitial tissue, with the ultimate goal to achieve a circumferential ablation pattern that will allow to silence these nerves, inhibit the trafficking between the brain stem and the kidneys in both directions, and therefore hopefully mitigating the effects of sympathetic overactivity, and therefore lowering blood pressure. This is just an illustration to give you a bit of an idea how these nerves run along the renal arteries, and the latest developments based on the research that has been done is that it is probably preferable to try to treat a bit more distally, where the nerves tend to be closer to the lumen of the arteries and thereby are easier accessible. and more reliably accessible by the catheters that are available. So we've learned a lot, not only about the anatomy, but also the physiology and how we can best use that in order to achieve more efficacy. I briefly want to run you through the biggest program that is available, and there's others. This is the Spiral Global Clinical Program. And it was a response to data that was published in 2014 to really first showcase in an off-med situation that yes, renal denervation lowers blood pressure, see how it works in patients who are on other medications, similar to what Jan has shown with silencing RNA therapies. And then also, how does it perform in a real world scenario, which ultimately is, of course, where we as physicians treat our patients. So I'll guide you through some of those very sophisticated study design where people were screened, had ambulatory and office blood pressure, sometimes were put on the same type of medication. This is now in the off-med trial, so people who were either drug naive to start with or were taken off their medication. If at the repeat visit elevated blood pressure was confirmed above a certain level, also by 24-hour blood pressure monitoring, they had drug testing to assess whether or not they were on other medications, and then they were randomized to either have a sham control or the renal denervation. And in this instance, there was a 3 months assessment for the primary endpoint, which was the change in blood pressure. And this was the baseline characteristics of the off-med pivotal trial, around 166 and 165 in each arm. So not huge numbers, but of course for device-based approach is quite reasonable. You see very similar middle-aged, rough age 52, and blood pressure was significantly elevated, still 160 over 100 on average, with office, and 150 over 100 roughly with 24-hour blood pressure monitoring. And if you look at the blood pressure reduction achieved at 3 months follow-up with renal denervation, either office around 9.2 millimeters of mercury, some effect of the sham control, but not dramatic. And if you look at the difference, clearly statistically significant, but I would argue also certainly clinically meaningful. The magnitude of the effect, as you would expect, less pronounced with 24-hour blood pressure monitor, but that is very convincing. And this was the pivotal trial to actually show that renal denervation lowers blood pressure, and it does so across the 24-hour period. And that's a critical aspect compared to sham control, where you see those curves are essentially superimposable. So it does protect patients across the 24-hour period. And again, we had a similar question to Jan in terms of siRNAs. We have very similar data on the on-med data set with longer term follow-up up to 36 months. And you see whether you look at 24-hour morning, daytime, nighttime, or office blood pressure, quite convincing reductions that are more pronounced than with the sham control. So renal denervation does lower blood pressure. And again, this seems to be the case in the long term as well. I often use the term that blood pressure management is a marathon and not a sprint, and we want to see that we achieve durable blood pressure effect, and that clearly seems to be the case with renal denervation if you look at these patients with long-term follow-up. In the full on-med cohort, while the trends were very similar and the magnitude of the blood pressure fall was very similar, there was certainly a more pronounced sham effect, and possibly associated with higher medication intake in those patients, which rendered the primary endpoint not significant in this particular study. But there's probably some explanations for this. And in that context, I think it is critical to also look at the Simplicity Registry, which is a real-world all-comer with, in this instance, more than 2,500 patients reflected with different risk categories: resistant hypertensives, patients with diabetes, isolated systolic hypertension, chronic kidney disease, clearly elevated blood pressure on 4.5 antihypertensive drugs on average. So really heavily medicated. Yet, if you add on renal denervation across those patients cohorts, you see a very consistent absolute change in blood pressure. So this is observational. There's no control groups there. This is what you see or what we see when we treat these patients in practice. But I think that illustrates, the consistency across those various cohorts, that on top of existing medication, you get significant blood pressure lowering. And it does not seem to matter whether your patients are on 1, 2, 3, 4, or more than 5 antihypertensives. You see a quite similar magnitude of the blood pressure fall. And again, this pattern that over time, the magnitude of the fall tends to slightly increase, whatever the mechanisms may be, but I'll take that any day. Now, there's some meta-analysis looking at both the efficacy outcomes across those studies with various technologies, either radiofrequency or ultrasound or alcohol ablation. And you see they're all on the right side of the curve. Similarly, if you look at safety outcomes, and that is, of course, important for an intervention where there's always the risk of potential problems, but safety has clearly not been an issue. Yes, excess site complications can occur with any kind of intervention, but certainly no signal for either vascular or renal adverse outcomes. And I think I have some slides in that regard. This is the data in terms of vascular safety. In those studies in which imaging was repeated, there was really no signal for a higher rate of renal artery stenosis, for example. And if you look at kidney function, eGFR in this context, here divided in those who have pretty good renal function to start off with, a mild decline over 3 years, as you would probably expect in patients with significant hypertension. But in those ones here with CKD stage 3, you see almost a flat line, not much of a change at all. And the least we can say, we do not do any harm to the kidneys. Data suggests that it may even be renal protective to some extent. And I think that would fit the pathophysiology we're aware of. I already mentioned that durability is probably a very important aspect. And we were fortunate to do a study where we brought patients back around 9 years after they had had their renal denervation. And this is the ambulatory blood pressure difference compared to baseline. We saw 12/9 millimeters of mercury. And these patients on average were on 1 less antihypertensive drug. And these patients are now roughly 10 years older. So with increasing age, we tend to see an increase in blood pressure. So again, this is reasonably convincing. But again, this is not controlled study. This is observational data. And we have similar ones from other centers. And the Australian experience, 2 from Germany. And again, you see very similar patterns in those centers. So putting it all together, I think it makes a relatively clear-cut story. Now, payers may have a concern. Well, if that works and if it's safe, well, everybody now wants renal denervation. By no means. I mean, if we look at patient preference, and that's something we should always take into account, not everybody wants renal denervation. A lot of people are very happy to take medication, and at various surveys here, some examples from Germany, it's usually around 1/3 of the patients perhaps would consider an interventional approach. Maybe over time, if there's more knowledge about it, it will become more. But again, it's not a concern that now everybody wants this. Is there clinical guidance? There's plenty of position papers from various countries, regions, etc. But most importantly, we have now guidelines, as I indicated at the start, that recommend renal denervation as one tool in addition to the others we have. It's another tool in our toolbox, which I'm personally very happy with. And this is the wording in the guidelines, which you can look up online. in patients with uncontrolled hypertension, ideally on antihypertensive drug combination. They recommend it in patients with resistant hypertension. The decision should be made in a shared decision-making process, and obviously the interventionist should be experienced. So really no-brainers, but it really reflects the evidence that is available. Two of those devices, ultrasound and radiofrequency, are now approved by the FDA. So this is really milestones, and I think we're now in the era of the third pillar of antihypertensive therapy, and that is interventional approaches. So with that, I thank you very much for your attention. And if that's okay, we will have some questions at the very end for both Ernesto and myself. And I would like to take the opportunity to introduce Professor Ernesto Schiffrin, who obviously does not need any introduction. He's the Professor and Vice Chair Research of the Department of Medicine at McGill University, Physician-in-Chief also at the Jewish General Hospital in Canada, Research Chair in Hypertension and Vascular Research. He has done breakthrough research, has won lots and lots of awards, amongst them the most prestigious from the European Society of Hypertension, the Björn Volkov Award, and has done groundbreaking research, particularly in the context of small arteries, resistance arteries, and in the context of systems such as the renin-angiotensin system and endothelin as well. And this is what Ernesto will cover in his presentation today. So we'll hear about other novel developments. And thank you so much for making the time, Ernesto. And we look forward to see your slides and hear your presentation. Over to you.
Thank you, Markus. So I'll start by sharing my slides. Here we are. So I've been asked to speak about endothelin antagonists and aldosterone synthase inhibitors, novel agents with new mechanisms of action. And these are my disclosures, which were mentioned earlier. So let me start by describing for you the endothelin vascular system, which is one of the areas that we've worked a lot upon since Yanagisawa discovered endothelin in 1988. We shortly after started working on the vascular effects of endothelin and its role in experimental hypertension. So let me show you over here, endothelin generated in endothelial cells is secreted into the underlying smooth muscle cells in the vascular wall and acts on ETA and ETB receptors to induce contraction, but also vascular growth and inflammation. It also acts either in a direct action on the same endothelial cells or in a paracrine fashion on ETB receptors that are present in endothelial cells to release nitric oxide and prostacyclin, inducing relaxation and vasodilatation. And so what is endothelin? Is it a vasoconstrictor or is it a vasodilator acting on these different vascular receptors? And actually, it's highly likely that, as shown in experimental models, it may be in normal conditions a vasodilator, but in individuals who are susceptible to hypertension, it becomes a vasoconstrictor through the action mainly of smooth muscle, ETA, and ETB receptors. So very early, as I mentioned, and I will go through this very fast, we showed that endothelin was increased in models of hypertension, and these were usually severe models of hypertension, such as the docosalt hypertensive rat or spontaneously hypertensive rats treated with deoxycorticosterone or aldosterone. And in these models of experimental hypertension, endothelin antagonists, and the first one we used, and we were the first to use in experimental models, was bosentan, which is currently used in the treatment of primary pulmonary hypertension. these endothelin antagonists were able to reduce blood pressure and antagonize the vascular remodeling effect of the target organ damage induced by endothelin. We then generated a mouse that expressed human endothelin in the endothelium. And I won't go into details except to mention that blood pressure rose slightly in these mice, but endothelial function was impaired and vascular remodeling of the hypertrophic type occurred, and as well inflammation in the vascular wall. And this was published in Circulation about 20 years ago and in the Journal of Hypertension as well. We then went on to create an inducible model to express human endothelin in the endothelium. And we looked at these mice over 2 weeks or longer, up to 3 months, and demonstrated that blood pressure did indeed in this inducible model rise with the overexpression of human endothelin, and that this rise in blood pressure, as seen here, could be antagonized by an ETA selective antagonist such as atrasentan. And when we looked at the 3-month elevation of blood pressure, and this is not shown in this slide, we found that there was significant target organ damage, vascular stiffness, vascular remodeling, endothelial dysfunction, but as well kidney damage, manifesting as reduced renal blood flow and increased renal injury, manifesting as proteinuria. In the meantime, the late Henry Crum in Australia did this study using bosentan at the time, showing that bosentan was able in humans, for the first time in this New England Journal of Medicine paper, to lower blood pressure to similar degrees at this dose as 20 milligrams of enalapril. And so there was no doubt that endothelin antagonists could be used to lower blood pressure in humans. However, bosentan produced rises in liver enzymes, and Actelion, the company at that time developing bosentan, was not ready to commercialize or develop bosentan for human hypertension, which is a lifelong disease, and in the presence of liver enzyme elevation, decided not to develop the endothelin antagonist for hypertension. More or less at that time, we did this study looking at human vessels in normotensives, stage 1 hypertension and stage 2 hypertension, and looking at expression of pre-pro endothelin 1 mRNA in the vasculature of these patients in our clinic. And we were able to show that neither normotensives nor stage 1 hypertensives exhibited significant elevation of endothelin message, whereas in stage 2 hypertension, as you can see here, there was increased message, which was shown to be specific with the antisense versus the sense, and again, the antisense versus the sense, and once more. So individuals with severe hypertension, like the experimental models, exhibited increased endothelin, both at the level of message in the endothelium and as well, not shown here, in the circulation. And we argued and advocated for many years that endothelin antagonists should be used in difficult to control or in resistant hypertension. And indeed, there was one such trial with darosentan, an endothelin ETA selective antagonist. However, this trial that was led by the late George Bacris showed in office blood pressure absence of difference between the lowering of blood pressure by darosentan and placebo. However, in this second publication by George in Hypertension, they were able to show that 24-hour ambulatory blood pressure measurement demonstrated indeed significant lowering of blood pressure by darosentan in this blue line. However, the company developing darusentan decided to drop the agent and did not develop or commercialize it for essential hypertension or primary hypertension. However, we now get to the present, where Idorsia, the successor of Actelion, develops a potent endothelin antagonist that is a dual ETA-ETB receptor antagonist, aprocitentan, potent and devoid of major side effects. And as seen here, this endothelin antagonist will block the ETA and ETB receptors on smooth muscle cells. It may also block the endothelial ETB receptors, which would result in a rise in plasma endothelin, which is the signature of a dual ETA-ETB receptor antagonist. So, does this result in lowering of blood pressure? And so, indeed, aprocitentan was used in resistant hypertensive patients in the PRECISION study, which is what I will be presenting now. And I'm showing you here the design and methods of this particular study, for which 730 patients were eventually recruited. These patients were screened on their individual background antihypertensive medication. They were then subjected to a standardized background therapy, which consisted of amlodipine 5 to 10 milligrams according to tolerance, valsartan 160 milligrams, and hydrochlorothiazide 25 milligrams daily. And this standardized background therapy was carried out throughout the study. Placebo run-in for 4 weeks was followed by randomization of the patients, always under the standardized background therapy, to placebo, aprocitentan 12.5 milligrams, or aprocitentan 25 milligrams in a double-blind 4-week Part 1 segment. This was followed by 32 weeks of single-blind therapy with 25 milligrams of aprocitentan, always under the standardized background therapy, triple therapy of amlodipine, valsartan, and hydrochlorothiazide. And finally, as requested by the FDA, there was a double-blind withdrawal for 12 weeks under either aprocitentan 25 milligrams or placebo, to which the patients were re-randomized, stratified according to their initial attribution to aprocitentan or placebo, followed by a safety follow-up for 30 days. Primary endpoint was the change from baseline to week 4 in Part 1 in mean trough sitting office blood pressure. I should indicate that this was AOBP, that is automated office blood pressure measurement. Key secondary endpoints are indicated here: the change from withdrawal baseline in sitting office systolic blood pressure, and other secondary endpoints such as ambulatory blood pressure at week 4 and week 40, and other post hoc analysis. Let me indicate as well that this population of resistant hypertensive patients was a high-risk population. 50% of the patients or more were diabetic. 30% of the patients had chronic kidney disease. 30% of the patients were obese. Many patients had sleep apnea, and about 20% had episodes of heart failure or had myocardial ischemic syndromes. So a very high-risk population of resistant hypertensive patients. Here are the blood pressure results. As you can see here, during the Part 1, there was a very significant, important placebo effect. However, there was a significant and similar lowering of blood pressure by aprocitentan 12.5 or 25 milligrams. This reduction in blood pressure remained constant throughout the Part 2 single-blind 25 milligram aprocitentan period. And then during the double-blind withdrawal, you can see that blood pressure remains controlled under 25 milligrams of aprocitentan, whereas patients that have been re-randomized to placebo, their blood pressure goes up actually to similar levels, perhaps their actual true blood pressure before the trial. And you can see here that the primary endpoint was highly significant for aprocitentan, 12.5 milligrams versus placebo, as well as 25 milligrams versus placebo. And the key secondary endpoint was highly significant for 25 milligrams aprocitentan versus placebo. Here you see the ambulatory blood pressure, which shows during the double-blind period, the significant lowering of blood pressure similar for both 12.5 and 25 milligrams of aprocitentan, and as well the significant reduction versus placebo during the double-blind withdrawal. It is important to note that during nighttime, blood pressure lowering by aprocitentan was highly significant, as you can see here, versus placebo, and during withdrawal as well. During daytime and nighttime, you can see that placebo blood pressure rose significantly versus the blood pressure of the patients under aprocitentan 25 milligrams, which remained controlled. I'll come back to nighttime control of blood pressure in the next slide. When we look at subgroup analysis, it's interesting to note that the elderly, of which about 30% were older than 75 years of age, had greater response than younger individuals. That individuals with increased urinary albumin excretion also had better results, and the same thing for the individuals with chronic kidney disease and a reduced eGFR, which is important because this drug does not produce hyperkalemia, for example, in comparison to mineralocorticoid receptor blockers, and therefore it is easier to give this drug to individuals with reduced eGFR. Over here to the right, you can see the response of albuminuria during the trial in part 2, the single-blind period, where albuminuria is reduced, and in the double-blind withdrawal, it goes up again under placebo and remains reduced under 25 milligrams of aprocitentan. What about adverse events? Serious adverse events were rare. Discontinuing study treatment was very rare, and only in aprocitentan 25 milligrams. The major side effect was edema and fluid retention, which could be controlled by additional diuretic. And this is important because it suggests that this agent requires the addition of diuretics. And indeed, some of the endothelin antagonist trials are using SGLT2 to compensate for any fluid retention that occurs under endothelin antagonist treatment. And again, you can see here edema and fluid retention in the patients during the double-blind withdrawal. There were a few cases of hospitalization for heart failure. There were 13 deaths, none of which could be attributed to the active agent. So the precision study demonstrates, in summary, that in high-risk patients with resistant hypertension, aprocitentan resulted in a clinically relevant office and ambulatory blood pressure lowering, the latter particularly during the night, and was associated with restoration of a normal dipping pattern in a substantial proportion of patients. Proteinuria was significantly reduced with aprocitentan. Fluid retention, edema, could be controlled by uptitrating the diuretic. And based on data from animal reproductive toxicity studies with other endothelin receptor antagonists, It is important to note that aprocitentan could cause birth defects and fetal death when administered to a pregnant patient and is therefore contraindicated during pregnancy. The agent has been approved by the FDA at and the European Agency at a dose of 12.5 milligrams to add on to other agents in the control of difficult to control or resistant hypertension. And in the United States, it is required that the female patients who may become pregnant should carry out pregnancy tests regularly to ensure that they're not on the drug if they become pregnant. Now, the other drugs that I was asked to talk about are the inhibitors of aldosterone synthase. And this slide shows you the biosynthetic pathway of aldosterone compared to cortisol and serves to compare the effects of inhibiting aldosterone synthase to the effects of a mineralocorticoid receptor antagonist. So let me point out the important 11 beta hydroxylase, or CYP11B2, and over here CYP11B1, one for aldo synthase, the other for cortisol synthesis. These two enzymes are very similar, and it has been difficult to develop inhibitors for aldosterone synthase for the 11 beta hydroxylase CYP11B2 that do not inhibit CYP11B1. But now we have these agents, and in fact there are several, and I will be showing you some data from these new agents. If we compare aldosterone synthesis inhibition with mineralocorticoid receptor blockade, I remind you that whereas aldosterone acts on the mineralocorticoid receptor to induce genomic effects, it also acts on a membrane receptor to induce non-genomic effects. And mineralocorticoid receptor antagonists only block the genomic effects. However, we will need a head-to-head comparison to be able to determine whether indeed there are differences between or advantages to aldosterone synthase inhibition versus mineralocorticoid receptor antagonism. However, it should be noted that in primary aldosteronism, taking out the adenoma is associated with better outcomes than treating the patients with mineralocorticoid receptor blockers, as has been shown by Giampaolo Rossi and other investigators who have shown the presence of atrial fibrillation, for example, much more frequent in the individuals who are treated with mineralocorticoid receptor blockers versus those in who the source of excess aldosterone is removed and the excess aldosterone in the circulation is eliminated. So let me show you the results of this phase 2 trial. 275 participants randomized in the study of baxdrostat, the first of these inhibitors of aldosterone synthase. You can see here the lowering of blood pressure in treatment-resistant hypertension that is induced by increasing doses from 0.5 milligrams to 2 milligrams of baxdrostat on both systolic blood pressure and diastolic blood pressure, and over here, the reduction of blood pressure over time. Does baxdrostat reduce aldosterone but not cortisol? You can see this here, where urinary aldosterone normalized for creatinine is reduced in a dose-dependent manner by baxdrostat. Serum aldosterone is also reduced in a dose-dependent manner by baxdrostat. Over here, you can see that cortisol is not reduced. If anything, it rises, and the same thing occurs with renin. So aldosterone is reduced selectively by baxdrostat, whereas cortisol is not, and this is associated with the significant reduction in blood pressure that I showed in these resistant hypertensive individuals. So 2 milligrams of baxdrostat significantly and substantially reduce systolic and diastolic blood pressure in patients with treatment-resistant hypertension. It reduced aldosterone levels, increased plasma renin activity without reducing cortisol, supporting its biological effect and selectivity. Baxdrostat demonstrated a favorable safety profile and was well tolerated, and it has the potential to treat disorders associated with aldosterone excess, including primary hypertension and primary hyperaldosteronism. There are other aldosterone synthase inhibitors. This is one of them, lorundrostat, which was published here, showing that among individuals with uncontrolled hypertension, lorundrostat was effective at lowering blood pressure at 8 weeks compared with placebo, which will require further confirmatory studies. There's also dexfadrostat, which is also a CYP11B2 inhibitor that suppresses aldosterone to renin ratio, indicator of sodium retention in healthy volunteers. And this agent is also being developed for aldosterone-dependent hypertension and primary aldosteronism. There's also vicadrostat. So we have a number of agents that can inhibit aldosterone synthase, and they are being developed particularly for primary aldosteronism as well as resistant hypertension, in which we know primary aldosteronism is often prevalent. And so in conclusion, after more than 20 years without new antihypertensive agents, we have novel mechanisms, potential targets, as well as a plethora of new agents and devices, as was shown earlier by Markus, in development or already approved. These new agents show promise to lower blood pressure and improve adherence to treatment, lowering cardiovascular risk, and generating hope that we can improve outcomes in hypertension, the #1 cause of burden of disease and mortality worldwide. And with this, I thank you for your attention. I'll stop sharing. Thank you very much.
Thank you so much, Ernesto. Fabulous presentation. And again, I think reason for excitement. You talked about two very exciting developments. One already approved, the others, really in various phases, but indicating quite, good potential to make it in the clinic. Could I ask you, Ernesto, before I go to the questions that we will get in the chat? Obviously, you already highlighted to some extent where you may see perhaps preferential use of those medications in the context of our conventional drugs, the ACE inhibitors, ARB, calcium channel blockers, diuretics. Where do you see kind of endothelin antagonists and aldosterone synthase inhibitors, assuming they make it into the clinic, which looks quite likely? Where do you see their differential use? Any kind of hints?
Yes. Well, as you are aware, endothelin antagonists have been approved in the US by the FDA, in Europe by the European Agency at the dose of 12.5 milligrams daily to add on to triple therapy in patients with difficult to control or resistant hypertension. So I expect that if they are approved in Canada, the situation will be similar and the indication will be similar. Many of these drugs initially make it in these conditions as an add-on drug, and then they may, once they are shown to be effective in post-marketing studies, their use is expanded into other conditions such as primary hypertension at earlier stages than an add-on in difficult to control and resistant hypertension. And I think that with aldose synthase inhibitors, we have a similar situation because, as you know very well, mineralocorticoid receptor antagonists are usually indicated as an add-on therapy. I use them a lot, spironolactone, and now we have all these non-steroidal receptor antagonists that can be used in resistant hypertensive patients in addition to triple therapy, including a diuretic. But as you're aware, we're understanding increasingly that aldosterone plays a critical role, not only in primary aldosteronism, not only in resistant hypertension, but potentially in less severe forms of hypertension. And there is a trend now to start measuring renin to determine whether renin is suppressed. And those patients may have excess aldosterone. Even if the plasma aldosterone is not elevated, they may have aldosterone effects. So I think that our use of these agents may change with time and move on from difficult to control and resistant hypertension to forms of hypertension with less severe blood pressure elevation and without necessarily resistance to treatment with our usual first-line therapies.
Fantastic. I'm conscious of time, but we have got a good number of questions. Another question was regarding hepatotoxicity. You did indicate that with endothelin antagonists, the early ones, there were signals. Any issues with the latest, like the dual endothelin antagonist, as far as you know?
Not as far as I know. Apparently, there is no liver toxicity with aprocitentan, so the side effects are minimal. And it is very well tolerated. So this drug has an advantage over the original agents that were developed, such as bosentan.
Fantastic. We have another question here in the chats relating to the renal innervation side of things. Question is if somebody's got renal artery stenosis, stent or renal denervation. I may respond to that. Obviously, renal artery stenosis, if it's severe enough, we would think this is, a classical kind of activation of the renin-angiotensin system. We have to be cautious with ACE inhibitors, ARBs, particularly if you have bilateral renal artery stenosis. But obviously, renal artery stenting or conservative medical therapy would be the way to go. Having said that, we do know, actually, there's nice data to indicate that patients who have renal artery stenosis also have a significant increase in sympathetic nerve activity. So the idea of using renal innervation potentially even in combination is probably backed to some extent by the physiology, but we don't have much data to go along. So at this stage, I guess, I wouldn't necessarily recommend renal innervation in the context of renal artery stenosis, see whether stenting or angioplasty on its own right would be useful, but that's a completely different kettle. Another question we have here, and maybe we'll allow another 2 or 3 minutes. Aldosterone synthase inhibitors as opposed to MRAs, spironolactone probably in particular, in the context of chronic kidney disease, where we know about the problems with hyperkalemia impact, sometimes negative impact on eGFR, which is not a real phenomenon, but in those patients who are kind of borderline, we're always concerned. Where do you see that panning out? Are aldosterone synthase inhibitors perhaps less likely to cause hyperkalemia? Are they perhaps easier to handle in those CKD 3B, 4-ish patients?
Yeah, it is possible. I think that has to be demonstrated. There is very rare hyperkalemia in the studies done with the aldose synthase inhibitors, but they weren't tried in individuals with more advanced kidney function impairment. And so I think it's premature to conclude, and this will have to be demonstrated that indeed, in contrast to spironolactone, for example, or even eplerenone, we don't have hyperkalemia at more advanced levels of kidney functional deficit, such as below 40 mils of eGFR. But I think this has to be demonstrated. It's also a question with the novel non-steroidal melanocorticoid receptor antagonist, although there is a certain notion that they may produce less hyperkalemia, but we have to really demonstrate that because, of course, people don't like to receive these panic calls over elevated potassiums when they're giving these agents in their resistant hypertensive patients.
Absolutely. I'll just summarize 2 or 3 questions, if I may. One was about, again, real innovation, re-innovation. Can that occur? That was always a great question. The answer is yes. There is evidence that re-innovation can occur, but that does not seem to be of functional relevance. At least in humans, there's some sheep data which indicate that some nerves can regain their function. But the signals we have from the human trials where the blood pressure lowering efficacy is maintained over, as you've seen, 9-10 years at least, this is unlikely to play a role. Another question from, I think, 2 attendees was comparison of the different technologies. So alcohol ablation is still, a small level of evidence available at this point in time, more accumulating, but most evidence for radiofrequency ablation therapies, but also now ultrasound. As far as I read the data, there is really not much difference, which is reassuring that any type of energy that is being used to successfully achieve a circumferential ablation pattern seems to result in similar blood pressure reductions. They have very similar safety profiles, no evidence for renal damage, vascular damage as such down the track, and prolonged durable blood pressure reduction. If you compare the individual studies, which is a bit difficult because endpoints have been chosen at different time points, the technology is slightly different. But my conclusion would be that each of those therapies seem to be safe and seem to achieve a very similar kind of blood pressure reduction, usually around 10-12 millimeters of mercury office within 3 months or so on average. So look, again, I'm conscious of time, and there's a number of more questions. Some of them we have covered. We have gone over time. I apologize to the audience, but I think it is perhaps a bit of a reflection, and we have still a huge number of people out there, which is fantastic. And I think it is perhaps a reflection of the exciting developments in this space. Remember, hypertension is the biggest killer worldwide and remains, the most important modifiable risk factor we have. And if we have more tools available, that can only be of benefit. So again, I would like to thank Professor Jan Danser, who had to leave a bit earlier, and Ernesto Schiffrin for terrific, wonderful presentations, really giving us lots of food for thought. Thank you to all the audience sticking with us, and apologies for going over time. And I would like to hand back to Anna. She's got a few things to bring this to an end. So thank you so much, everyone. You have a wonderful evening, night, or morning, wherever you are, and hopefully we'll see you again down the track. Thank you all.
Okay, everyone. Thank you all for attending today. After you close out the Zoom window, a survey will appear. We would appreciate it if you take the time to fill it out and give us feedback on the session. Just a quick reminder that the session was accredited by the Royal College and approved by Thrombosis Canada, and you may claim a maximum of 1.25 hours. The session was co-developed by us, Hypertension Canada, and Thrombosis Canada, and was planned to achieve scientific integrity, objectivity, and balance. And the certificates of attendance will be sent out within the next day or two to everyone. Thank you all. Bye.
Thank you. Bye.